Okay, you're good. I'll make you host. And what time is your meeting going till, George?
12.
Okay. All right. If you could just make me co-host.
Yep. Captioner, Jeanette, if you wouldn't mind just doing a test again. We can make sure it's going through to Facebook, YouTube.
Yep. Good to go.
Great. All right. Thank you so much, Betsy.
You're welcome.
Good morning to those of you who just joined us. We'll be getting started in a few minutes. We are already live streaming to YouTube, so your image and sound may be captured. And this meeting is being recorded. Good morning to those of you who have just joined us. This is the annual meeting of the Alzheimer's Disease and Related Disorders Commission, or fourth quarter meeting. We'll get started shortly.
George?
Yes, good morning, Laurie.
Hey there. Can you email me a link? I for some reason am only able to get in on my phone.
Sure.
Where was the this link sent? I'm sorry, I missed it somehow. Was it in a GoToMeeting invitation a long time ago, quite a while ago?
It should have been with the meeting materials I sent last week.
Okay, well, let me look.
So it's okay. I'll send it again, Laurie.
You mean with the minutes?
Yeah.
Okay, then let me look there again.
Here, I'll just email you the link now.
Okay, thanks so much.
Sure.
Yeah, I just had 2 sets of minutes in that with that email. No link.
There was an earlier email.
A previous one. Okay.
Yeah.
Sorry about that last minute thing on my part.
No worries.
I'm still on COVID time. Here it is. Okay, thanks.
Sure.
Okay, I'm here.
So Laura, I think you're still on both. So if you want to leave the meeting on your iPhone and just keep it on your computer.
Laura, you're apparently on mute.
Whew.
Still on mute, Lori. We can't hear you, whatever you're saying.
Good. So good morning, folks. This is the annual or fourth quarter meeting of the Alzheimer's Disease and Related Disorders Commission. If you give me a second, I'll just count to make sure we've got enough folks and then we can get started. Okay, well, as folks are still coming in, I'll go ahead and get started with the housekeeping, and then I'll turn the meeting over to our chair, Laura Bowser. Bear with me a second. Okay. So due to the active state of emergency, this is an electronic meeting. I'm going to keep pausing as I let people in, sorry. This is an electronic meeting pursuant to item 4-0.01 of the 2020 Appropriation Act. Meeting notice has been provided. The meeting is being recorded and minutes are being taken. All votes will be conducted by a roll call of voting members. Meeting materials are posted under the Alzheimer's Disease and Related Disorders Commission's quarterly meeting tab at the link posted on the slide. Members of the public are able to live stream this meeting via the DAR's YouTube page. Please be advised that if the live stream is interrupted, we will need to pause the meeting until it's restored. Public comment will be accepted by email or phone to my attention. Public comments that were received by yesterday, June 7th, 2021 will be read, or if lengthy, summarized during the meeting when we reach that agenda item. Members, we ask that you please keep your microphone on mute unless you are speaking, as this helps reduce background noise. And also, before you speak, if you could please state your name. Not only does this help your colleagues on the commission know who's speaking, but it also helps Cecily with documenting the minutes. And this is particularly important as our captioner will be trying to capture the discussion. Members and guests, if you have your video enabled, please be aware the system may capture your image and video in the public streaming and recording. Please only use the chat feature if you have a technical issue or other issue not related to the business of this meeting. Chat comments are not captured in the live stream or the recording, so are not available to members of the public. You may also use reactions to do a thumbs up for agreement or clap to raise your hand to speak, although this feature may not be used in place of a verbal vote in a roll call vote. If you'd like to view the real-time captioning of today's meeting, please click on the CC button on your menu bar and select Show Subtitles. Zoom participants will be able to turn on or off closed captioning. The YouTube streaming will automatically include the captioning. For all votes, we will do a roll call, and you'll be asked to indicate your support with an A or a yes, opposition with a nay or a no, or you may abstain. I'd like to thank the DARS video teleconferencing team and the DARS communication team for making this electronic meeting possible. I'll now do a roll call of members in alphabetical order to confirm attendance. Laura Bowser.
Here.
Travonia Brown-Hughes.
Here.
Karen Darner.
Here.
Chris Desimone sent his regrets. Karen Garner.
Here.
Rick Jackson.
Here.
Karim Khan. Kim Kuttner.
Here.
Carol Manning.
Here.
Lori Filippo.
Here.
Lana Sargent.
Here.
Margie Shaver.
Here.
Crystal Thompson. Pam Teester. Ishan Williams.
Here.
And I see Karim Khan has just joined us, so I'll mark you as present. So Laura, we do have a quorum, so I'll turn it over to you now, and I'll pull up the agenda. Give me a second.
All right. Well, good morning, everyone. I want to, before we actually move into the regular business of the meeting, I wanted to go ahead and thank two members whose term are ending, and sadly, I wish I could do this in person. But I'd like to thank Karim Khan, who actually was appointed in 2007 by the governor at large. Karim, thank you so much. You immediately stepped in and took over and offered to chair the coordinated care work group. And thank you also for offering to continue until someone else is reappointed in your place. But you will be greatly missed. And I hope everyone can find a way to say goodbye. And then also I wanted to thank Lori Filippo, who actually was first appointed in 2013, also by the governor at large. And Lori, as many of you know, was the chair prior to me, so I can't actually thank her enough. She taught me so much, especially when I was first getting started and didn't really understand a lot of how DARS was structured, and just really took me by the hand and has led me, and she's going to be greatly missed. So I wanted to thank both of you for your service. And with that, I will go ahead and turn the meeting to order. Because we met briefly, I think last month, we didn't actually go around and introduce ourselves, and it's been a while. So I did want George, if you could just call individuals out and everyone to say who you are, kind of your role, and why this commission is important to you. So I can start if that helps you, George. Laura Bowser, I am chair of the commission. I think this is my 6th year, I'm not sure. I day to day, I'm an HR consultant, but what brings me to this commission is my mother, who had early onset Alzheimer's and passed away in her 50s. And I also am a volunteer with the Greater Richmond Alzheimer's Association chapter.
Thanks, Laura. I'll start with members, and then I'll ask guests to introduce themselves as well, please. Travonia Brown-Hughes.
Hello, good morning, everyone. I'm Travonia Brown-Hughes. I am an assistant professor at Hampton University. Let's see, my background is in gerontology, and my father actually is in the mild to moderate stages of Alzheimer's disease, and also too, my grandmother passed away from vascular dementia. So I'm happy to be here and happy to be serving Virginians in any way that I can.
Thank you. Karen Darner.
Hi, I'm Karen Darner and from Arlington, and I'm a retired speech therapist in the Arlington schools. I'm really passionate about the work that the Alzheimer's Association has done. It's been extraordinary. I've learned a lot. And my mom and my younger brother have both passed away, with my mother with vascular dementia and my brother with more of a general title. And but during the COVID, his death was a result of the COVID-19. And I think everybody here has just done a terrific job, and we've almost gotten through everything. So it'll be interesting seeing everyone in person again. That's quite a goal of mine. So take care. Great.
Thanks, Karen. Karen Garner.
Hey, good morning, everybody. Karen Garner. I'm in the Richmond area. I actually am the advocacy manager for Virginia, Maryland, and DC for the Alzheimer's Association. But I'm a member of the Alzheimer's Commission as a former caregiver for my husband, who had younger onset Alzheimer's and passed away 5 years ago.
Thank you, Karen. Rick Jackson.
Good morning, everybody. I'm Rick Jackson, and I am the retired executive director of the Riverside Center for Excellence in Aging, and spent 25 years of my career working with older adults in various settings. My personal interest was my late mother had Lewy body dementia, so I was obviously involved in her care, and this is my second term on the commission. I'm very happy to be here. Thank you.
Thanks, Rick. Khurram Khan.
Hi, this is Khurram Khan. I've been on this commission for 4 years, and thank you, Laura, for all your kind words before this. I'm based out of the Northern Virginia area. I'm involved in mostly IT services. I run a small home care services, which is where I got into the Alzheimer's and dementia programs.
Thank you, Khurram. Kim Kuttner.
Good morning. I'm Kim Kuttner. I reside in Williamsburg, Virginia, and connected to Alzheimer's personally and professionally, and serving through the Center for Excellence in Aging and Lifelong Health currently. And July will be 1 year that I'm honored to serve on this commission with you.
Thanks, Kim. Carol Manning.
Good morning. I'm happy to see everyone, at least virtually. I'm Carol Manning. I am a professor in the Department of Neurology at UVA, and I'm director of the Memory Disorders Clinic and the Virginia Alzheimer's Disease Centers here. I also had 2 grandparents with Alzheimer's disease, and hope to be a part of the solution to this terrible disease.
Thank you, Carol. Lori Filippo.
Well, thanks, Laura, for your kind words about my, I guess, 2 terms and time as chair of the commission. The work of the commission is so important to me because of my family history, like many of you, parents both with different kinds of dementia, and also that I was for 35 years director of an adult day center here in Richmond. The majority of the people that we served had one kind of dementia or another. So it's been my life's work, now retired. We'll miss all of you.
Thanks, Lori. Margie Shaver. Oh, sorry, Lena Sargent.
Hi, everyone. It's good to see you all again. I've been on the commission since 2018. This last year, joined as vice chair. I'm honored to actually be on the commission. What brings me to the commission are multiple things, both personal and professional. I'm assistant professor at the School of Nursing at VCU, also a clinician in geriatrics as a nurse practitioner for 17 years, and do researchers and vascular and AD So, and also have 2 grandparents with vascular AD. So that's a close factor to my heart. So glad to be here with you all. I also chair the data and research group.
Thank you, Lana. Margie Shaver.
Good morning, everybody. Margie Shaver. I'm in Roanoke. I'm a retired marketing professional. My mom, my grandmother, and 3 aunts all had Alzheimer's. I've been involved with the Alzheimer's Association for about 20 years. This is my first year on the commission, and I couldn't be more delighted to be a part of this group.
Thank you, Margie. Ishan Williams.
Good morning, everyone. I'm Ishan Williams. I'm an associate professor at the University of Virginia in Charlottesville. I am a researcher who studies older adults with dementia and their family caregivers. I'm really interested in health outcomes and how to make aging in place a more inclusive space for our older adults as they live with dementia as well. So happy to be here. I'm also in my first year on this commission and have enjoyed every minute. Thank you.
Thanks, Ishan. And guests, Carter Harrison.
Hello, my name is Carter Harrison. I used to do the public policy work in Virginia, but I am now in the DC office, helping to oversee our policy work nationwide. I know I said the last meeting would be my last. This meeting will be my last meeting as we transition to Josh, who will introduce himself here in just a minute. And I've been at these meetings since 2002. So I've seen a lot of them, and I've seen a lot of folks make contributions, and I really want to thank those that are cycling off of the commission for their contributions during their time here. It's important work, and I really appreciate all the time you guys put in. Thank you.
Thanks, Carter. Joshua Myers.
Hi, Josh Myers, taking over Carter's role, or at least attempting to, as he has moved up to the national office. I've joined the association about 2 months ago, so I'm still coming up to speed. Prior to that, I was a government affairs director associate for a number of different firms in Richmond. And way back when and Margie, I grew up in Salem, so right next door to Roanoke. I used to work for a legislator in the House of Delegates from back down that way. And he accidentally goofed up and got himself elected to Congress. So he's there now, and I'm been in Richmond for about 13 years now, and I'm just looking forward to rolling up my sleeves and helping in any way I can.
Great, thank you, Josh. Marcia Dubois.
Good morning. I'm Marcia Dubois. I'm the Deputy Commissioner for the Division for Community Living here at DARS. And I also had 2 family members who had Alzheimer's disease and later passed away. So glad to be here and be a part of this group.
Thank you, Marcia. Kathy Miller.
Good morning. I'm Kathy Miller, and I am the Director of Aging Programs and Services in the Division for Community Living at DARS. And I had a father-in-law with vascular dementia and a grandmother with Alzheimer's, both of whom have passed away.
Thank you, Kathy. Have I missed anybody? I think I got everybody.
Okay. Well, thank you all for going around and brief introductions, and welcome, Josh. And Carter, I would have thanked you again for all your support over the years if we'd known you were joining us one last time. So one thing I did want to mention before we get started is that we probably will be meeting in person soon, which is just incredible. But it also brings, of course, challenges. I don't think we've ever been so successful with our work groups as we have during the state of emergency, being able to electronically meet. So just so you know, I think we'll be able to continue with our work groups probably for the next month or so, but we're waiting to hear directions, and probably we'll be meeting again in person in September. So with that said, as usual, we always start the meeting with a reminder of why we're here. So as defined by Virginia Code, the role of the Alzheimer's Disease and Related Disorders Commission is to 1, examine the needs of persons living with Alzheimer's disease and related disorders, as well as the needs of their caregivers, and ways that the state government can most effectively and efficiently assist in meeting those needs. 2, develop and promote strategies to encourage brain health and reduce cognitive decline. 3, advise the governor and General Assembly on policy, funding, regulatory, and other issues related to persons suffering from Alzheimer's disease and related disorders and their caregivers. 4, develop the Commonwealth's plan for meeting the needs of patients with Alzheimer's disease and related disorders and their caregivers, and advocate for such plan. And lastly, establish priorities for programs among state agencies related to Alzheimer's disease and related disorders and criteria to evaluate these programs. So with that, we need to review and adopt our meeting agenda. And I know George pulling it up now. Does anyone have any changes to this agenda? If not, can I have a motion to approve?
Yeah, I move to approve.
This
Thank
is Rick,
you.
I second.
Thank you. George, will you go ahead and do the roll call?
Sure. So the motion is to, we have a motion on the table to approve the agenda as presented. As I call your name, please vote yes or no, or yay or nay, or you may abstain. Laura Bowser?
Yay.
Travonia Brown Hughes?
Yay.
Karen Garner?
Yay.
Karen Garner?
Yay.
Rick Jackson?
Yay.
Param Khan?
Yes.
Kim Kuttner?
Yay.
Carol Manning?
Yay.
Lori Philippa?
Yay.
Lana Sargent?
Yay.
Margie Shaver?
Yay.
Ishan Williams?
Yay.
Okay, thank you. So the motion is approved and the agenda is adopted as presented.
Thank you. So next we need to review and approve the minutes from the previous 2 meetings. That would be the March 9th meeting as well as the April 20th. I don't know if everyone has had a chance to review those, but I'll give you a minute or 2 to review them, and just let me know if you have any corrections to these minutes. Okay, if no one opposes or provided any corrections, then the minutes are adopted. And we don't need an actual roll call for this vote. And with that, George, we move into public comment. Did you receive any public comment?
I did not, Laura.
Okay. Well, then I guess we can move on to our first thing of business, which is actually Deputy Commissioner's report. And Marcia, I will turn it over to you.
All right. Well, good morning, everyone. I thought I'd start off with some funding updates and just share some good news about several good funding announcements. The first is that our area agencies on aging received $1.2 million in new vaccine funding that will allow them to receive some funding for activities they've actually already been engaged in. And this funding will allow them to distribute information about COVID vaccines, to identify people that may need help getting a vaccine, identify folks who are having trouble getting transportation to vaccines, knowing about getting their second vaccine, providing, communicating with their local health departments, providing any kind of support that they might need in getting to the vaccine, not just transportation, but sometimes getting personal assistance support if needed. reminding people of their vaccinations, general outreach about vaccination efforts. As I mentioned, our area agencies on aging have been engaged in these kinds of activities for many months. But they've been distributing flyers, posting information on their websites, working with their local health districts. Several have been hosting vaccination clinics for some time. And so we're really proud of the efforts that they've been engaged in already, and excited that they're now having an opportunity to be paid for some of this work. Kathy Miller, whom you've met already, our Director of Aging Programs and Services, has been working with representatives from the Department of Health and the Department of Medical Assistance Services to identify individuals who are homebound or medically fragile and unable to leave their homes at all, to make sure that someone can come to their home and administer the vaccine if that's what they would like to have happen. So she's working to make sure that the area agencies on aging can work with the local health department and the Department of Health to identify those folks and make sure that they get vaccines. Also, our No Wrong Door program also received some funding for vaccines, primarily for outreach efforts. So then in addition to that, DARS has also been appropriated through the American Rescue Plan, $34 million in stimulus funds passed by Congress to speed up the recovery. That most of that funding will go to area agencies on aging, but it hasn't been appropriated yet. That funding needs to be appropriated through Virginia's General Assembly. We expect that to happen by July. And this will really be helpful to address a lot of the needs and increased demand for services that occurred throughout the pandemic. So that will help address increased needs for meals, in-home services, things like access to equipment for broadband, all kinds of things that we identified throughout the course of the pandemic. So, and that funding should be available through 2024. So in addition to that, we've got some news on our grants funding. We're very pleased to announce that the Administration for Community Living awarded DARS that falls prevention grant that I mentioned to you. We applied for at the last Alzheimer's Commission meeting. We did receive that award, and this will allow us to expand the falls prevention program of Matter of Balance and Bingo Size across the state of Virginia. Both programs can be held online or in person with health precautions taken. The award amount is $287,000 for a 3-year grant period that runs it began on May 1st and it will run through April 30th, 2024. So we're very happy about that. We did apply for a lifespan respite grant, and this will be a 5-year grant proposal that we applied for. So we're keeping our fingers crossed that we receive that award as well, which would allow us to expand respite voucher, that program that we have currently. So in addition to that, we also applied for a HUD grant, which we have not done before. We submitted this grant. It's a housing modification program for older adults through HUD. And it's a 3-year grant opportunity. And if awarded, it will allow Virginia to expand home modification programs for low-income elderly homeowners throughout the Commonwealth that are considered substantially rural. So we would be partnering with area agencies on aging, 4 of them in rural areas. And it will allow for us to pay for housing repairs that are less than $5,000. So we're very excited about that opportunity, and we certainly hope that we're successful in that as well. And then finally, I just wanted to mention how thrilled we were with the Governor's Conference on Aging this year, and our partnership with V4A, or the Virginia Association of Area Agencies on Aging. V4A did a fantastic job in planning for the event. And we had more than 300 people participate. Recordings for the sessions can still be accessed for those who attended. But it was a 4-day virtual event with just really rich sessions on all kinds of topics. So we were very, very pleased with not only the turnout, but the content. So that is it for my report. Thank you.
Thank you. I love hearing all the positive news. And I'm sad that I missed the conference this year. That sounds wonderful. Okay, with that, then we want to move into the Dementia Services Coordinated Report with George.
Thanks, Laura. I'll just share that so you can see it as I go through. So let's see. So as usual, I've attended a lot of online offerings, lots of webinars. I just want to give a shout out to the continued excellent series produced by the Governor's Conference on Aging. So they had another 2 webinars since we last met, one on COVID-19 and elder abuse, and then Medicare coverage and COVID-19 vaccine and preventative services. The other couple that I wanted to focus on were the Dementia Friendly USA has produced an evaluation guide for dementia friendly communities to use in evaluating what they're actually achieving. So I think this is a really positive development, and it reflects the increased number of dementia friendly communities that are applying and receiving federal grants, as well as local and non-governmental grants, which typically would require them to do some form of evaluation. So I think that's a really positive step, and the guide is clear and gives good examples of communities and that have produced successful evaluations. So I think this will be really useful for our dementia-friendly communities in Virginia going forward. The other one that there was a dinner and dialogue about dementia-friendly African-American congregations, which I thought was a really rich and valuable discussion. As we know, this is Alzheimer's Disease and Brain Health Month, June, and many African-American congregations, or many congregations generally, are doing Purple Power Sundays or Purple Sundays to get across a message about brain health and dementia in their services, which is fantastic. There were several virtual conferences in the last couple of months. The Greater Augusta Stop Elder Abuse Coalition, which has its one-day annual event. This is always full of interesting information and examples of efforts to rein in elder abuse. The Governor's Conference on Aging, I'll just echo Marcia, it was a fantastic conference. Lots and lots of really great sessions. Unfortunately, I didn't have the opportunity to attend as many as I'd like, but I will be watching some of the recordings, which are available until November. The Benjamin Rose Institute sponsored a geriatric workforce enhancement program, supported Ohio Collaborative Alzheimer's Disease and Related Dementias Project Summit last week, which was also very interesting and had lots of good information and examples of how communities are using Dementia Friends Initiative to successfully raise awareness in target sectors like first responders and things. So it was a really interesting half-day session. So I've done a few trainings. I've even done one in person. So I delivered a training for the State Police Academy So they've been asking me to come and deliver a training on dementia awareness and knowledge for each cohort since, I guess, the beginning of last year, maybe since 2019. So there were 50 cadets in the room, and we were back in our normal room. The previous time we were in a huge gymnasium. So it was very nice to get back up in front of people. And they had lots of good questions and sharing some personal experiences. So I think it's such a valuable opportunity to raise awareness among the police force. So I'm grateful that they continue inviting me. I've done a few in-services for long-term care facilities as well. And then Leading Age, Virginia and I are doing quarterly virtual Dementia Friends Champions sessions, training sessions. So we were doing them monthly, but realized that was a bit of overkill. And if we do them quarterly, that should be plenty. We may start doing those in person, but I think having the virtual option is good. It saves us from having to travel long distances as well. Coming up, I'm doing a Dementia Friends virtual session this Thursday for our local library in Charlottesville. They've asked me to do that quarterly, which is great. I will be attending the Project Lifesaver annual conference in Orlando at the end of August to deliver 2 sessions on dementia awareness for first responders. So I'm looking forward to that. There's no new updates on data. I'll just say that there is a webinar this afternoon if anybody's interested on translating the BRFIS caregiver module into action. 2 presentations, I think, from New Jersey and North Dakota on how they've used the data to promote policy change. So that'll be interesting and certainly applicable to our BRFIS work group. Attended my usual meetings during the quarter. So Virginia Caregiver Coalition, Christy Jensen and I did a presentation on May 20th on the AARP Long-Term Care Scorecard, the Long-Term Care Supports and Services Scorecard, highlighting the caregiving section where Virginia ranks 48 out of 51. So we talked through why that is and what would need to change in order for Virginia to move up the rankings. And we'll continue giving updates to the Caregiver Coalition on that. Let's see. That's about all I want to focus on there. Grant writing and administration. So just a couple of things here. So the BOLD Act grant that we have with the Department of Health, or the Department of Health has with us, has hit some obstacles over the past 9 months. One of the key requirements of that project is to hire a brain health coordinator to be housed at Virginia Department of Health. With the pandemic and the hiring freeze that was in place for a while, that obviously pushed that back, and then they've had some staffing issues and are hopefully are going to get that brain health coordinator in place in the next month or 2. So we're hopeful for that. But in the meantime, we've been moving forward with our efforts under that grant, many of which are being shepherded by the Commission. So they were very pleased with our work on the grant so far. I had a meeting with VDH last Friday. I will be meeting monthly going forward, which is good because we've had not a whole lot of touch. So this will, I think, things are definitely looking more positive in terms of where that grant is going. The feedback from CDC so far has been understanding and supportive, which is fantastic. They certainly want us to succeed. So I will keep you posted on as we move forward with that. The other thing I wanted to let you know is that the ACL, the Administration for Community Living, released a second round of Alzheimer's Disease Program Initiative funding yesterday. we as DARS have not been applying in the last year or so because they previously had language saying that if you had received funding in the last 4 years, that you would be one at the back of the queue, and unless you were doing something very novel and different to what you were already offering, then you weren't likely to receive consideration. So the language does appear to have changed. I had a quick look at the funding opportunity yesterday, and it does suggest that we might have a better chance if we applied. So they were mainly concerned with folks who've had funding. Well, I can't remember exactly, but it has changed, and I think it might be worth exploring. So that project will be due on August 2nd. So I'm going to have a closer look at that next week when I have some time and consider putting a project together. I think we have a number of things that we could fold in under an ACL grant that are sort of in gestation or about to get going. So that could be a great opportunity for us. Just on policy tracking, so Carter might have something else to add, but apart from the funding for dementia care coordination, $150,000 a year going to UVA for care coordination provided by UVA and the Alzheimer's Association, and the work group to study better services for people with dementia-related behaviors who are showing up in emergency rooms and being sent to state hospitals. That work group is gearing up. There's a message going out to stakeholders later this week, I believe, with the first meeting scheduled for June 23rd. So DARS, we will be presenting on existing dementia services. That work group will also be examining RAFT program in Northern Virginia, which you may recall Alice Straker from RAFT presented to us, I think last December, December 2019, so before the pandemic. And that program is being studied as a model for how for a service that could support people as they're discharged from psychiatric hospitals and returning into community, either to home or to long-term care facilities. So that's going to be an important work group. I've had 2 calls from members of the public in the last week who either professionally or who had family that are facing just this issue. Both have, when I mentioned the work group, both indicated their interest in providing some comment to that work group. So I think this, it's certainly addressing a very strong need. So, and then at the federal level, maybe Carter can certainly speak to this better than I can, but there are a few pieces of legislation that have been put forward. The Alzheimer's Caregiver Support Act, which would provide grants for training and support services for families and caregivers of people living with Alzheimer's disease or related to dementia, has been introduced to both the House and the Senate. It's currently in committee. And the other one I thought was interesting was HR 2517, which is recommending that CMS, the Centers for Medicaid, it's the Center for Medicare and Medicaid Innovation, test the effect of a dementia care management model. So that would be very interesting if that moves forward. So that could provide an impetus for dementia care management nationwide. So Carter, I don't know if you have anything to add on this.
George, I'll let Karen fill in any of the gaps folks might have. The one about the dementia case management, I do think is very, very important. And I think it speaks to how we have sort of been at the forefront with this, and the federal level is also taking notice of this type of device for aiding people with dementia. Let's say mechanism, not device. Karen, I don't know if you have anything else you want to add to it, but I think it's really that piece of legislation is of particular interest to me.
Yeah, the enact. I don't know if you're familiar with that, George. I don't see it on there. I didn't hear you go over that.
Which one? Enact? No, I don't.
Enact, E-N-A-C-T. So that's a bill that was just put forward probably about a month now, which promotes equality for Alzheimer's and dementia clinical trials, not just with the people participating in the clinical trials, but also the staff that run the clinical trials as well, so that the potential people that are participating will be more comfortable and more likely to participate. So it's promoting equality for the clinical trials. If you'd like, if you don't have information on that, I can send it. I can send it to you, and you can share it.
Yeah,
I'll do it right now.
Right. All right. Thanks, Karen.
Mm-hmm.
So that's it for me. If anybody has any questions, I'd be happy to answer them.
Great. Well, thank you all. Thank you, George, for all the updates, and good luck with some of your in-person trainings that are getting ready to happen. And I would be interested, Karen, so thank you for sending information over on that. And without further ado, I guess we'll go ahead and move into our work group reports. We actually have a lot to cover today. But the first report is actually going to be the nomination committee. So I will turn it over to the chair of the nominating committee.
Yep, so that's Rick.
Thank you, George. Thank you, Laura. The nominating committee was able to meet this morning before the commission met. And I'm very excited and happy to report to you that Laura Bowser has agreed to continue and offer herself up as chair for the next 2-year term. And Lana Sargent has offered herself and agreed to serve as vice chair for the next 2-year term. And these individuals, and this is the slate of officers that the nominating committee would present to the commission today. I understand that at this point, I should allow for other nominations if they would so want to come from the rest of the commission. So let me give you that opportunity. Hearing none, I suppose, George, we would take a vote.
Yep, so we'll need a motion to approve that slate as presented.
This is Margie. I'll make a motion to approve the slate.
I'll second it. This is Lori.
Okay, so the motion on the table is to approve the slate as presented, which is to elect Laura Bowser to the chair of the commission and Lana Sargent as vice chair for the 2-year period starting July 1st, ending June 30th, 2023. So I'll do a roll call vote in alphabetical order. Laura Bowser.
Aye.
Geronia Brown Hughes.
Aye.
Karen Darner.
Aye.
Thank you. Karen Garner.
Aye.
Rick Jackson.
Aye.
Karam Khan.
Yes, aye.
Kim Cutner.
Aye.
Carol Manning.
Aye.
Lori Philippa.
Aye.
Lana Sargent.
Aye.
Margie Shaver,
Aye.
and Sean Williams.
Aye. Sorry.
That's all right. Okay, so the motion is carried, and Laura Bowser is elected as chair for another 2 years, and Lana Sargent is vice chair.
Well, thank you all. It's my privilege to continue serving and working with you. And I've also just want to thank Lana for stepping in and for all her support and work and leadership as well. And so I look forward to continuing. With that, I'm going to actually hand it back to Rick for the training work group report.
Thank you, Laura. My pleasure. George is going to bring up something for you to look at, which is the draft of the primary care toolkit. I want to start by thanking all the members of the work group and George for really a heroic effort that's gone into this, because as you'll see, it's a significant amount of information covering a wide swath of things that we're all so concerned about as we serve individuals with cognitive impairment and their caregivers. And we had really rich discussions about language and protocol and algorithms. And as a result of that rich discussion, I think important improvements were made that you'll see today. One of the most important pieces of change in the language was a discussion of the use of the word screening versus diagnosis. And as you all know from your work, it's very, very important that we have a clear understanding of the use of those two terms. So as you see information here, you'll see that screening, thank you, George, is a way we described what would typically happen in a primary care office. You know, that a primary care practitioner and his team, upon using these tools that we're going to provide to them, will see indicators of concern, of cognitive impairment. And as a result of finding those areas of concern, we'll refer to specialists or experts, if you will, in regards to a diagnosis. And we all know those experts to include neurology, and they also include memory care assessment centers like the one at UVA, like the one at SEAL, where a diagnosis would in fact occur. And so that was a very important discussion that we had, and one that you will see in this language in regards to the steps. So let me stop for a minute so you can look at that language and those two steps. See if you have any other questions or concerns, because at the end of this, we're going to take a vote, because we believe, we suggest to the commission that they would adopt this language and these algorithms and protocols so that we can begin using them in the new year as we educate primary care and other clinicians to have them better serve their patients with cognitive impairment. Anybody from the work group or any of the other folks want to take a look at that and make any comment? George?
Yeah, just a little bit of context. So under the BOLD Act grant, one of the projects is to have this piloted at 3 clinic sites. So this isn't the end of the end. This is really what would go out to be piloted, and those we would expect to incorporate feedback from the clinics that would actually be using, the 3 clinics that would actually be using this in that pilot project to improve and improve it before it goes out for a more widespread audience. But we did take on board all the feedback that we received at the commission meeting in March. So thank you for that. I'll just point out a couple of things. So we made it a bit clearer in terms of the steps. So we have 4 steps. Step 1, the screening. Step 2, referring for diagnosis. Step 3, follow-up care planning. And step 4 is connecting patients with services and supports. We've added quite a bit of information to the toolkit itself, so including that introductory text, which members had asked for at the last meeting, which just covers some basic information about why this is needed and talks about disparities in the incidence and prevalence of Alzheimer's disease, and highlights the importance of the annual wellness visits, and also ties this to the dementia state plan. So the idea is that the 4 steps that you see in the primary care toolkit will correspond to that brochure that we showed you last time. So I'll just show that quickly. This was the kind of flyer to alert primary care practices to the availability of this resource. So here you have the 4 steps again: cognitive screening, referring for diagnosis, follow-up care planning, connect patients with supports and services. So we're really trying to tie those together and make it pretty straightforward for the primary care practitioners. Let's see. I don't want to spend too much time on the brochure, but Rick, if you're happy for me to move forward through and show the commission the rest of the changes.
Yes, I do want to say a couple other things I'm really proud of in regards to the work group. And as George shows you more, you're going to see a listing of the memory care centers in the state. And I have to admit, there are more than I knew. So I was very happy to see there's more of them. I remember at one time in my career, I was limiting the fact there were so few, and I can see now there are more. And the second thing I'm very proud of is that there is a mention of a billing code where clinicians who are engaged in doing this screening can actually create more revenue for themselves. And those are 2 really important pieces of information you're going to see.
Can I make a comment about that code, though?
Yes.
That code is limited to nurses and physicians, which does not make it useful for a lot of people who provide critical care for people with dementia and their families.
Thank you. George, go ahead.
Just before I get to the code and the list of clinics, all of the practice tools that were developed by Act on Alzheimer's that we're including, we are able to rebrand those. So we'll be including the Dementia Capable Virginia logo, which we'll talk about later in the meeting today, on these tools with a acknowledgement to Act on Alzheimer's, so they don't have to be branded Dementia Friendly America, which I think is good. I've also gone through all of these and just made sure that we have all local Virginia information on here. You'll see under diagnostic uncertainty and behavior management here right at the top that we highlighted that referring to a specialist, neurologist, neuropsychologist, geriatric psychiatrist, memory disorders clinics. Again, included local numbers for area agencies on aging and things like Virginia Navigator, which weren't on here before. I won't go through all of those. Those are the screening instruments. And then referring for a diagnosis. So we have a list of those memory assessment centers serving Virginians that are on All's Possible. So there's those. With the billing information, so I know Carter Harrison had felt that it would be important to have the billing codes here. So in that follow-up care planning, we've added a brief discussion of that code, which is to provide a written care plan. I guess, as Carol said, it is limited to doctors and nurse practitioners, so it may not be as useful for example, a dementia care manager developing this care plan would not be able to charge under this billing code. The Alzheimer's Association has a very good explanatory document about this billing code, giving examples and context for that. So we've included a link to that rather than trying to create something better, because I know we won't be able to. But just enough information to explain what the code is and why you would want to use it. The National Alzheimer's Disease Resource Center, which is an offshoot of the ACL, Administration for Community Living, had created a billing guide for other dementia-related services, including the care planning code, but also including a number of other codes, such as for providing counseling for people living with dementia. So again, we have a link to that rather than trying to reproduce what they've done, which is a large amount of work. But if practitioners are exploring how to bill for dementia-related services, that would be a really great resource. So we want to make sure we have that available for them. I think those were the major changes. I did add at the end of the toolkit a new section on. Sorry. So in the connect patients with supports and services area, we've included the referrals that we're putting in the dementia roadmap. We've included all of the area agencies on aging information. I think we had a link to it before, but I think members felt it would be better to have an actual listing so that people don't have to go to yet another place to find out how to contact another agency. So we've included all of that. And key organizations and information on other dementias. So I think thanks to the feedback from the members of the commission and the great input from the work group, we've really improved this a lot. And I feel like it's ready to go to those pilot sites, which are yet to be determined.
So George, do we at this point take a vote, or we just allow for other discussion? What would be your pleasure?
Well, if there's any other discussion, this would be a great time for it.
So hearing none, I'm going to make a motion that the commission accept this draft toolkit for primary care practices as presented this morning.
I'll second. This is Laura.
Okay, so the motion on the table is to approve the primary care dementia practice toolkit to move forward to 3 pilot sites. I'm not sure when that will happen, but probably over the next 3 months. I'll do a roll call in alphabetical order. Laura Bowser.
Yay.
Travania Brown-Hughes.
Yay, excellent job.
Yeah.
Thank you. Karen Darner.
Aye.
Karen Garner.
Aye.
Rick Jackson.
Aye.
Khurram Khan.
Yeah, aye.
Kim Kuttner.
Aye.
Carol Manning.
Aye.
Lori Filippo.
Aye.
Lana Sargent.
Aye.
Margie Shaver.
Aye.
Ishan Williams.
Aye.
Okay, so the motion is carried, and we'll move forward with the pilot project for the primary care dementia practice toolkit.
Excellent. Well, thank you. I want to thank Rick and especially George and the entire work group for all your work on this. There was a lot of discussion and it's truly rich. And I look forward to seeing the feedback from the pilot. So fingers crossed, and hopefully we'll have updates. Okay, so with that, we're going to move to the coordinated care work group, and I will turn it over to Karam Khan.
Hi, everybody. So we had a technical issue when we were supposed to meet on June 2nd. That's last week, to continue working on the dementia roadmap. And we had to cancel the meeting. In lieu of the meeting, we reviewed the latest developments of the roadmap via email. So, you know, while it's great that we are able to meet so often, sometimes these technical issues do derail us. In April, George had sent the dementia roadmap draft out to the stakeholder feedback. The comments were received, which were uniformly positive. In fact, there were some very good suggestions, such as including information about driver evaluation and a list of memory assessment centers serving Virginians. We are reviewing a selection of the caregiver portraits, which has been provided by Michael Geller for inclusion in the dementia roadmap. Portraits and quotes illustrate, you know, different stages in the caregiving and also highlight the need for caregiver. The roadmap and a large number of works has been graciously provided by Cindy Paulin of Art of the Journey. George met with the Virginia Department of Health on Friday, June 4th, with the next steps for design and layout of the roadmap by the VDH communication team to be discussed. And depending on VDH, which is designing and printing 10,000 copies of the roadmap through BOLD Act grant support, the final version should be available for approval. That's pretty much what happened. Unfortunately, you know, we couldn't meet. But we did, I think we've everybody, all the members had given some feedback to George as well as from the public. So we are on track and to present it at the September 14th meeting. I'll stop here, and George has also shared the report, but if you guys have any questions, please feel free.
I'll just add one point if I may. So when I spoke to the VDH on Friday, the Department of Health, so in the initial BOLD Act proposal, we had printing for 10,000 copies to be distributed through area agencies. Many of the stakeholders who responded said, how can we get these? So clearly there's a very strong demand, and I made that quite clear to the health department. So we'll be asking for probably printing more copies. I suspect that first 10,000 will go very quickly, but the demand seemed very strong, and the feedback was very positive. So I'd again like to acknowledge our colleagues in Washington State, the Dementia Action Collaborative, who developed the original roadmap and gave us such an excellent starting point. It certainly helped us as we tailor this to Virginia.
Well, thank you, Karam, and thank you, George. I've enjoyed working with this work group. I'm looking forward to seeing the final product, and love that we're bringing in art and actual quotes and just really personalizing it to our state. So thank you again for all your work. If there are no questions about next steps, coordinated care work group, I'll keep it moving, and we'll move into the data and research work group, and I'll turn it over to Lana.
Great, thanks. Well, I want to thank, first of all, I want to thank everyone for the vote of confidence on the vice chair. I really appreciate that. Like I said, it's really an honor been an incredible experience to be a part of it. So I appreciate it. And I want to also thank the Commission for having a quick meeting to help this work group move some initiatives forward. We first met, we went into a brainstorming on how to, achieve the two major steps from the, from our state plan, and connecting researchers with populations that otherwise don't always have the opportunity to engage in research, and how do we get more participants to engage in AD research, which is a big initiative in itself, and in addition to how we can also in that step collect data on what is happening across the Commonwealth with research. And so just to remind everyone, we did the brainstorming initiative and decided we really needed a platform in order to communicate with individuals. And so last meeting we voted on the VCU Capstone Project, which allows us and the team there for us to put a proposal in for the team there to join us as a legacy legacy project, to allow us to develop a platform in which we can tailor to our focus, which is dementia research. And so we approved that at the last Commission meeting, and it has been provisionally accepted by VCU, which is good news. And we expect to hear sometime in September the team that we'll be working with. But our work group is not done. We're back in the brainstorming phase, and again, open to all here to brainstorm, because I love the ideas that we had when we were just discussing approval of the capstone. There were a lot of great ideas that came up. So we went back into the brainstorming idea and talked about really the focus. We have to spend some time before we get assigned a team. What is our focus? Understanding our stakeholder groups, potentially what it might look like, as well as maybe even conducting a needs assessment. So we spent a lot of time brainstorming, discussing the potential audience for the app. We went, in a variety of different directions as far as what could the app create. Could it have multiple sections? There was ultimately broad agreement that the initial stages of the development of the app, because remember, this is just the first step. Hopefully, the hope is that this platform could potentially evolve into something, progressive over the years, that it becomes, the format that we can use. But there was broad agreement, initial stages, that it should be for researchers and potential research participants to engage and have access to research that's happening across the Commonwealth. And there's overall definitely agreement that we should create something that makes it easy for individuals to view these and connect with researchers, or view the research that's happening in a way that doesn't require a search engine or to know keywords, to make it very user friendly. And so those are the pieces that we'll be working on, over time with this group. We did discuss also, kind of what research groups would it really focus on, because we've had previous initiatives across the state that have been very biological and bench research science focused, and the group largely agreed that this would be human subjects. So really trying to connect individuals, real-time caregivers, or individuals with dementia to research that they really want to be a part of. So really focused on human subject research. The app has a potential to expand from its initial development. So I don't think we should lose track of that, but at least staying focused on kind of one nugget or one piece and kind of working through the details of that will help us expand out. We did talk about a lot of the resources that are already out there, and sort of, we certainly don't want to create or recreate, resources for people, but it did come up that often individuals who are looking to access research or access resources in general have to untangle the web of resources that are out there. So we did discuss that potentially we may include or keep some discussion in there about how we might be able to untangle that for people. And certainly there was a discussion about how do we untangle getting access to research too. And so that's the main focus here. So the immediate steps is actually brought up by Connie Kugels, who's in our work group, who's been a part of the Center on Aging for years, as well as a part of the commission in the past. There was a research focus group done in 2014. So in light of not wanting to repeat a whole lot, we're going to go back and review the surveys of the attendees from that focus group. The overall feeling of the work group was to start thinking about our stakeholders and doing some needs assessments of those stakeholders, which should really help us determine how do they want to interface with it, what would it look like, what would they use it for. We want it to be usable and not just, of course, another resource that is hard to access or difficult to use. And so we're in that early phase of thinking about how do we use the focus groups that have or the data from the focus groups that have already been conducted, and then thinking about doing some assessment, additional assessment of stakeholders that would potentially be using this resource so that we can do a good needs assessment to help create a foundation for brainstorming kind of going forward in the development of it. And I think that's it for me on the report. Anybody on the work group with me, please feel free to fill any gaps I may have missed. And I'm also open to brainstorming. I do see and envision, the group does envision doing some of the brainstorming and the heavy lifting, and of course, bringing pieces back to the commission to brainstorm on and show as the development happens. That would be our workflow process. Thoughts?
One thing I'd like to lift up to the whole commission, if I may, Lana, is one area that we talked about a lot was how to describe the people that we're trying to reach. So not necessarily the researchers, but the potential participants in that research or members of the public who might be interested in what research is going on. What do we call them? So those some of the suggestions were things like me, so a button that says me that you could press. Do we say caregiver? Do we say member of the public? Do we say individual? Interested? I don't know. So that was something that we did talk about quite a lot, but didn't get any consensus as yet. But if members of the commission have thoughts about what do we call the people that we're trying to reach, that would be super helpful. You don't have to come up with it now, but I just want to plant the seed.
So give an example, we have a member on our group, Fonda Neal, who when her mother was diagnosed with mild cognitive impairment, one of the first things she said she did was go to the web, to try to search for things. Initially, she really did want to get her mother in a clinical trial of some sort and found it very difficult to search through and really figure things out. And then the next level was just searching through to find resources, right, and knowing where to go. And so we did spend some time about, how would she identify herself, right? Or how do you identify it? And maybe that the caregiver is looking to engage their loved one in a clinical trial to help, or maybe the individual themselves who's just diagnosed. And so identifying that individual when they come to the app, what do we call them, I guess is what we did spend some time talking about. So that may come out certainly in the development phase of the app when we start to develop it, but certainly we're open to discussion and ideas. And certainly if people want to talk about stakeholders here, that would also be useful. So if we're going to do a needs assessment and reach out not only to the researchers, that's certainly the side that maybe a little bit more tangible, but certainly getting an assessment at how individuals or caregivers may engage or want to engage with something like this to connect themselves or loved ones with an app. Any ideas on other stakeholders that we should be surveying, or how we should go even about doing a needs assessment of our stakeholders is also open for discussion and brainstorming.
Yeah, I'd just like to add, I'm super excited to be working with community partners and building something like this. I think it's incredible that the commission has the opportunity to do that. And I think what the work group is struggling with is there's so many different directions we can go in and we can't bite off everything. So where do we start? And I don't necessarily have a right or wrong answer for that. So I would like to hear from other people that work in the field that are supporting people or caregivers right now. What language resonates? Not all at once.
Well, I was struck by the discussion about language that's more appropriate for professionals as opposed to the lay. And so I think it really is important to make that distinction between what those of us who've been doing this for a very long time automatically know what it means, as opposed to people who are looking at it for the first time. And but I hear you having that discussion already, so I know that you're already going down that road and concerned about that. I would just encourage you to continue to do that.
It's a good point, especially when it comes to research, right? And access to it and understanding what it is or what it may potentially do to help their loved one or themselves.
This is Ashawn. I just, okay.
So we can hear you.
Okay. I think I'm pausing. I think we're processing, probably if people are like me, they're processing what you just said. But given what Laura just mentioned about how big this can be, like, and not knowing how to narrow it down, I think that's where, like, I'm not sure where to target the feedback, because I think that there's, like, once we know, like, the target of, and I'm actually moving away from using that term target and saying focused population or focus groups of who we're really interested in getting to use this, because I love the idea of asking stakeholders, but it needs to be multiple stakeholders, and how you could have them be your beta users, like try to use things, and then that then spreads out. It helps with the language. I think for me, that's always been something that I've really found to be really helpful with families. Also, I do, and I know you all may know, I'm certain you do, Senior Navigator, working with Adrian at that group. Now they, also do a lot of community outreach and engagement with their programming. And they also do the caregiver hack, which I'm sure you're aware of, but they also would have probably a lot of informed sort of decisions based on just what they do this kind of thing, and so they just may be themselves a really good partner to reach out to engage in these conversations. So but again, I mean, it's exciting to hear what you all are doing, and but those are just my initial thoughts as we're processing.
Those are really helpful, especially the idea around engaging a group of stakeholders that may also want to beta test it, right? Pilot it and give us feedback as it develops. Maybe even in the initial phases, reaching out to a broader stakeholder group than what we think might actually be users, because we might be surprised that if a navigator was sitting with someone, they may actually use the app to engage them, side by side or something like that. So coming up with a list of stakeholders is definitely top our list. Yeah, that's great.
Lori.
And that's a,
Yeah.
sorry.
What I was going to suggest too is that the Dementia Friends Network has probably struggled with a lot of this already, and they may also have ideas about how they refer to themselves and each other in their work. But I also think the Navigator family has had a lot of experience with consumers and providers and, wide variety of folks with the populations they, I won't say target, but they serve. So build on some other people's experience with the language issue, the labeling issue.
Labeling, right.
And this is Kim. So TIPA Snow's positive approach to care uses care partner, but people don't know, they don't identify with it. So it hasn't caught on yet.
Yeah, I would agree with that. It seems sound, but people can't relate to the idea.
I want to echo that we continue to use the word caregiver where appropriate. I'm not saying care partner doesn't often fit the relationship, but you're right, caregiver still is the word people associate with.
The caregiver and care receiver.
Those are great points. And thanks, Ishan, for mentioning the caregiver hack, because the hackathon, I think that's great. And it makes me think that we should be talking to Dr. Lindsay at least at some level on this. So he's on a committee that I have in Charlottesville. So we're meeting next week. So I'll ask him if he'd like to maybe come on as a consultant for this project in some form, at least to give us some feedback. Because I know that in the hackathon, the caregiver apps tend to be things that can help the caregiver in their caregiving rather than maybe necessarily connecting them with research projects. So I think he'd be quite interested in this.
George, Thea Pepperell, who is the faculty is overseeing the capstone, she also has participated in the hackathon too. So that's a nice connection. She's familiar with the caregiver. She's been a part of the caregiver hackathon development too. So that's great.
George, Lori here. Remember a couple of years ago, we did try to engage Adrienne Johnson in one of the work groups. And I think she was interested, but they were going through some changes at that time. And it might be worth circling back to her as well as a resource.
Yeah, great idea. Yeah, she was in one of the work groups when I joined DARS, but then, as you say, she got very busy.
Well, thank you all.
Very helpful.
Yeah, no, I love this conversation.
I would say that will be the first step. We've also discussed as a group getting data collection from the app, which is the next level, right? Because we have struggled. I've been on the data work group before even, and we really struggle with getting statewide information. And so this may be also an opportunity for us to collect data too and interface with individuals. Of course, what Carol Manning had mentioned, of, it would have to go through certainly an IRB and a protected, if they agree to give us information when they engage, but it may also be a way for us to collect information too, but that will be our next, that's the next phase. Certainly the development of it and the stakeholders involved in it are the bigger foundation step for us. So, well, if you think of anything, hindsight, let George and I know. We'll be working on those pieces, and especially sort of thinking through the stakeholders and the needs assessment piece of things. Thank you.
Thank you, Lana. And thank you all for your ideas. That's really helpful to get us moving and started. So if there's no other questions, do please feel free to reach out if you think of anything additional for us. we'll go ahead and move into the BRFIS work group with Dr. Manning.
Sorry, it took me a minute to get off of mute. Although we are not an official work group, I would like to thank the people who have been on the BRFIS meetings with me. I think it's an exciting endeavor. What we are doing is looking at the BRFIS, the Virginia BRFIS data, in particular regarding dementia and caregiving. And we've met to come up with ideas about how we want to move forward. I think there are several ways we can mine the data, and different people in the group have different ideas on where they would like to focus most. I have a postdoctoral fellow who works with me who is, I think, going to meet with George either tomorrow or sometime later this week, so that she can get a better understanding of the data, since George, among us, has the best familiarity with those data. And we are starting by just looking at the basic demographics of the caregivers in the state, caregivers for dementia and people with dementia in the BRFIS data. And I think just reporting even on the basic statistics, the basic demographics is a start, because we don't know what that looks like. And then each of us are going to pursue particular interests based on what we see in the data, with the goal of helping people both in the state and nationwide understand what we look like in Virginia in terms of caregiving and dementia based on the BRFIS data. And hopefully we'll publish it so that we can not only let people know, but provide scholarship as well. So I think it's a great opportunity. And I really thank the people who have volunteered to be in that sort of temporary work group.
Well, thank you, Dr. Manning. And I've had the privilege of joining that work group, and I can honestly say that as someone that doesn't do data, it's overwhelming to look at all the different possibilities with it. So I look forward to learning more as you all move forward. All right, so that is actually the end of our work group overview. And with that, we're going to actually move into discussing branding that we've been working on. George, I will turn this over to you to give a little bit of feedback.
Thanks, Laura. Just before I do the branding, I just want to let folks know that one of the under the BOLD Act grants that I was talking about before, we will be running the BRFIS caregiving and cognitive decline modules again in 2022. So we'll be pitching that as part of the Department of Health BRFIS. Every year they take solicitations on which optional modules to include, so we'll be part of that process in the fall. So I might want some input from the commission, or at least the work group, as we move forward with that. In terms of the branding, so last meeting we had a look at a few logos. I wanted to lift these up to you as possibilities. I think you had seen a version of the top logo here, the top two, and then the one at the bottom is a kind of variation on that top logo. So I guess I'm opening this up to feedback. A couple of questions we had for you was the top logo you'll see. So at DARS, we have a kind of a vertical and a horizontal logo, or versions of our logo. So we wanted to create something similar for this. I guess the question we had was the hyphen. I know this is high level stuff, but the hyphen in the dementia capable in that horizontal logo, maybe a hyphen wouldn't look so great in the top logo. So perhaps we dispense with the hyphen altogether. And I guess the other thing I'd be looking for feedback on is the color scheme. And of course, which design you prefer in this.
This is Rick. I actually like number 1 best and the top. And the other question I have would be, how would a hyphen improve or in any way change someone's perception of the logo? I'm not sure I would understand that.
Yeah, so I mean, typically, if you were talking about something that's dementia capable, so a dementia capable system, you would hyphenate that as it's a phrase that's modifying a noun. I think to differentiate this initiative from that kind of standard generic dementia capable, we probably want to lose the hyphen. That's just my suggestion. I think it also would look a bit cleaner.
This is Kim. I like the top 2, the top 1, but then sometimes you need something that fits that stationary, and with or without the hyphen is fine with me. And I also like the idea of the sort of picture of the family or the village, because it affects more than just a couple.
This is Margie. I like the top 1 best. I don't love the hyphen. I don't know if I love the colors. I just personally like darker colors, and maybe if the word Virginia was more of a navy, but then it's going to blend in with the dementia capable words. So I get that. I like the 3 people for the same reason that Kim does. If we're talking about Virginia and being capable, that it's more than just you and that person trying to figure this out. So I like the first one best. And I think it would reproduce better too in print or media or whatever. And that, of course, is real important.
This is Carol. I also vote for number 1.
And I agree. This is Lori, and I prefer 1 myself, but with regard to the issue of color, generally the blue end of the spectrum, blue-green end of the spectrum is not good for older eyes. It's a part of the spectrum that and starts looking gray. So the warmer colors are better. And I'm looking at the trifold brochure, the Dementia Resources for Primary Caregivers, and the color that you've used there in contrast is more of a teal. Teal has a little more durability in terms of aging eyes than the lighter blue. And on that brochure, although it's used sparingly, I think it works well with the more rust and the purple. So that creates a bit of a color template that might be used in other publications as well. 3 colors that all work in various combinations. But I think the lighter blue, the baby blue, just fades too much. The other comment I would make about the figures, when I first printed this on my computer, I thought I was having ink problems because of the fade on the edge of the logo. And I realized it was a message, an intentional message. I guess the 3rd person, is that intentional? The 3rd person fading away. I wasn't involved in the history of developing it, but that was sort of what came to mind. The person on the left is the person with dementia, and they're fading. Or is that
I didn't think of that. I didn't get that.
Well, then why is that? Why is the color lighter on on the left end of the logo?
I think it's just the design. I think, I mean, I didn't do the design, but I think it's just, if you just put all three the same color or the same darkness or lightness, I think it might just not be pretty, for lack of a better word. But that's a very interesting observation.
Yeah, I see it as equally out of focus, maybe, or softening. But and in a way, whether you have dementia or not, you could be in that kind of situation. But I see the three people being a really essential need. When you get down to the last one, in fact, that is an M to me.
Yeah.
There's nothing else I can do with it. But I really like the first one completely.
The top three also interconnect with each other. They overlap, and they're holding on to each other.
Right.
I see that.
Yeah, I think the symbolism of the top one is very strong.
I do too.
The color, I think, could be warmer, and the third person on the end the message is weaker because the ink is not as bold.
What about using this mustardy color that was also here? It's on the warm side. I don't know what you call it, burnt orange?
That sort of rusty color?
Rust, yes.
Possibly. Or
if blue.
Yeah, or if there's a reason to have a third color, then I think that teal blue is a bolder color than light blue in terms of sort of holding up to the
So
other.
would we recommend not fading the logo and just having it all clear?
Right.
So no one misconstrues it that they're fading away and
there's some hidden message.
Yeah.
I would agree with that.
Yeah.
I didn't get that, but that is a very interesting observation.
Yeah, I see them as three.
Now that you've said it,
deeply unfocused.
I can't unsee it now.
Well, although some caregivers may say, well, that's me there on the left end, but I think other people would interpret it on other ways.
I don't know. It would be good to have the designers
talk about
as part of this conversation. I mean, what matters is what we see, but the designers may have some suggestions on not making the person look like they're fading away, but not just making it a hard three people the same color too. I don't know.
George, I'm here if you want. Do you want me to speak up?
Yep, please. This is
I can start my video. I'm designed the logo, and I appreciate your feedback on it. No, I did not intentionally fade it for that purpose, but I think it's a great observation, as someone said. I mean, I honestly think that you might consider that because of, it would resonate with people more. The fact that they do feel like dementia, people living with dementia that are fading away. So I kind of feel the opposite, that you might like that interpretation, but I can make a solid color. It was more of a design aspect rather than intentionally fading, but I could make it a little less prominent maybe, but I just like you guys to consider that interpretation, because that's what makes a logo effective. It's that people can see it and get meaning out of it. And so.
Yeah, I agree.
This is Travania. I really like number one. And I was, and not to, shake things up or anything like that, because I'm fine either way, but it might not be a bad idea if you had more than one color just to denote maybe diversity. But again, I'm not trying to, throw in start another conversation, but if not, maybe more of a prominent color without so much of the fading. But, I really like the logo overall.
Yeah, I will definitely can modify the colors. You mentioned teal, although I think you also said it, you stay away from blue green, which is teal. So I'm a little confused on that comment, but you know, it could be more of an orangey yellow, like you said, a warmer color instead of the blue. I think that would work.
Would
Yeah.
variations of the purple?
That's what I was thinking too, the purple.
Consider, since purple is the Alzheimer's color. And I know that the dementia capable words I'm thinking are purple. Sometimes, you know, on our screens, it might look different than it actually is too. But some type of variation with the purples, would that be a good idea?
Well, this is a deep purple, so I kind of made it, try to differentiate it from the dementia purple, but also be in that family.
Mm-hmm.
But you're saying make that the dementia capable a different purple?
No, what I'm saying is making the people a
variation of a purple. Okay.
Yeah. And then whatever whatever you would do to make that look right.
Yeah. I did want to stay away from making it too purple, right?
Yeah, I get that. Yeah.
Unique.
Well, it sounds like we have consensus on which logo we all like. Everyone likes the first logo, and I do too, actually. And that we prefer it without the hyphen. But maybe, George, next steps would include just looking at different colors, things that are, you know, ADA friendly and friendly to the elders and look good. We'll trust the designer. So
all those things.
Yeah.
Thank you for your feedback.
Thank you.
Thanks. You're muted.
Sorry. I appreciate everyone's feedback on that. And I look forward to figuring out what logo works best. And I think going forward, that's really the agenda for today. I did want to talk about future meeting dates. So as you all know, we will be meeting September 14th. And then the final meeting of the year will be December 14th. As I mentioned earlier, most likely in person, but we won't know for sure until, I guess, after the special session when they determine what next steps are happening. But with that, I wanted to open the floor up to any new business.
Can I jump in there, Laura?
Yeah.
So I just wanted to highlight another document that I sent out with the meeting materials, which was the ASPE, Assistant Secretary for Planning and Evaluation report on the impacts of COVID-19 on Medicare beneficiaries with dementia. So that was something I had talked about briefly at the last meeting in March, and had hoped to show you the video of that, but didn't have time. I just wanted to, so that this report was under development at that point, but I wanted to make sure that everybody had a copy of this, and I just wanted to highlight a couple of things in that report. One is that, like the fee-for-service data that we use for prevalence in Virginia, it doesn't include Medicare Advantage beneficiaries, so it only includes about I think about 45% of all Medicare beneficiaries. But even so, I guess the most striking information in that report was that after controlling for all other factors, the likelihood of being diagnosed with COVID-19 was 1.5 times greater for persons with dementia, and their risk of dying was 1.6 times higher than their cohorts or counterparts without dementia. And that almost 1/3 of the beneficiaries with dementia who were infected with COVID-19 died as a result, regardless of whether they lived in community or in a long-term care facility, which I thought was really interesting. And that was about twice the mortality for total Medicare fee-for-service beneficiaries. But I'd encourage everybody to have a read through that report. It's very interesting, and as governments respond to the lessons learned from the pandemic, this is a really important one for us to make sure that we all understand and can share with the people who are making decisions.
Thank you for sharing that, George. I read through and thought that assumption does make sense because they're not understanding why, so taking off the masks, not washing hands. But how would that correlate to a toddler where the toddler's brain is similar to the late older Alzheimer's, where they were still in preschool and maybe forgetting I don't know. But that does make sense that it's not related to brain function, but just hand washing and precautions and staying 6 feet away.
Yeah.
Well, thank you, George. Is there any other new business? All right, if there isn't, then I will go ahead and join the meeting. I want to thank you all for your time today and for getting through as much as we did.
You did. Yeah.
Thank you, everyone.
Thank you.
Laura. Thanks, everybody.
Thanks,
Bye,
guys. See you in
everyone.
September.
Hi, everybody.